Thank you for this great invitation, Vanessa, and thanks for all your preparations and fantastic work, and for your team. I'm honored to be here, and I'm still sort of lightheaded of having a prize yesterday, so thank you for that too. I'm a clinician, and I see many patients with CDG, and of course, all of us would love to find new therapy and try to ease the patient's life and be creative. I want to talk about that and teach you a little bit of biochemistry, if it's allowed. I'll try to be smooth. So first of all, I need a lesson in pushing buttons. This one or this one? Vanessa needs a lesson too. Which one you pushed? Yeah. All right. So it is really important before you start any therapy that you're absolutely sure about the diagnosis. So the first step is to have like a really correct diagnosis, also having all the biochemical details, and the second, to understand what's going on. And in many disorders, even where we know the diagnosis, we don't completely understand the little details of the biochemical changes. So the easiest way to treat a disease, and especially in inborn errors of metabolism, to give a diet. So it sounds like an easy way, but even giving a diet can be risky. And I think any doctor who will start you or your child on a diet has to think about it, if that has maybe any side effects. So let me show you this new disease. It has been discovered in the last 2 years through different geneticists and biochemical people and clinicians who work together discovering this new disease. And you already heard about this disease. It's a recognizable pattern because the patients have liver disease. They do have low blood sugar levels, and they have sometimes a cleft palate. And this is not really a full cleft, but you see that this is recognizable. If you look into the mouth of your child, you see that it's not completely fully formed. This is a pattern we see in almost all of the patients. So that's a developmental problem. And the patients usually have heart involvement as well. If I'm speaking too quickly for the international participants, then please just say that you cannot follow me anymore. So when we see this pattern of low blood sugars and liver involvement, and maybe with heart or without heart problems, then we have to do our CDG testing, and then we have to do genetic studies to be sure that the diagnosis is correct. So remember, we do the transferrin screening. There are some centers who are using different methods, but this is an easy method to use for the initial screening. So actually, what you do is you run the gel, and you get a pattern at 4. What does that 4 means? It means that you have 4 antennas on your protein. The sugar chains have 4 endings. So that 4 band means that this is a normal pattern. You have all the antennas you needed. You have a functional, good protein. So in this new disease, we see a very different pattern. And if you just look at my antennas, they are all sort of crooked. They are missing sugars. So look at all the variations. See, some of the proteins are missing, like the antenna with both endings. There are other ones which are truncated, so they're missing the terminal sugars. all kind of variations. This is just an example that you have a complex problem. You're not just missing an antenna, you really have a problem with building that antenna. And what's usually missing is this yellow sugar, and that we call galactose. So do you know in which food you have galactose? Lynn, very good. Lynn says milk. So thank you. The patient cannot build the sugar chains because somehow the milk sugar doesn't get built in. So if you miss that little piece, your whole glycosylation is not working. So let's say the first idea I have, I want to treat this. I want to find a cure for this new disease. How would you start? First, you probably would go back to the initial idea, the only curable, or maybe I should say treatable disease. I'm just reversing my thoughts, you see, because unfortunately, we see that some of the 1B patients, so the patients with the classic disease, which we thought it's curable, they still have symptoms after adequate treatment. So I would say treatable. So let's go back to the knowledge we already have, you know, what we learned from other CDGs. And then let's think about the biochemical background. That's Hod's favorite part. Never publish anything before you understand it. And then design a safe therapy. And I'm really concerned about any therapy we are starting up because we are changing something in the body of our children, and we really have to be cautious with any new therapeutic ideas. So remember, this was the treatable type of CDG, where we have a defect where you see that red line, and you cannot convert that fructose, so that fruit sugar, activated fruit sugar, you cannot convert to mannose 6-phosphate. And that mannose, remember, we heard it many times, that sugar, that's really a special sugar. You have to have it because you have to have it activated, then you build it, and your sugar chain is kind of full of green dots, so we need that mannose there activated. So when you have a problem in this known defect, you would see that the red line is cutting the pathway, so you cannot make that activated mannose. What you think, let's give mannose, let's push mannose to the system. Maybe if you add that, then you can push the whole pathway and you can proceed and make your antenna and place it on your protein, and it will function again. So that's the idea behind dietary intervention. So now the question is, can you use this sort of idea to treat this new disease? We know that there is something with galactose, with the milk sugar. So can we figure out something about that? Woo, pathway. I simplified it for you, and I try to, show you how to walk through this. And just please stay with me. You have glucose upstairs. So glucose is just sugar. Lucky for us, that's easy to imagine. That's what we eat and makes our life sweet. That glucose we need, otherwise we don't have enough energy. We cannot function, we faint, and we cannot concentrate anymore. So that's glucose. What's glycogen? Glycogen is the stored form of glucose. We store it in our liver, we store it in our muscle, and when we need it, when we don't have enough food, we just free it. We just break it down, and we get the sugar, and then we can function again. So, galactose, remember, the yellow dots are our milk sugar. We can make it ourselves too. We can make a little bit, but usually we drink milk or we eat cheese if we are Dutch. And why do we need it? It's really very essential, the galactose. We really need the galactose in our body. And as you see, not only because we are using it in many pathways, like we can turn it back and use it in the other pathways, but we have to use it for glycosylation. Okay? You see the pathways connecting to glycosylation because you need those sugars, all of the sugars. So you see I killed the enzyme. That red line means that enzyme which is deficient in this new disease, then it changes the whole biochemical balance because it has to stay in balance. And in CDG, something goes wrong, and that balance is turned around, and we cannot restore it. So what happens if you just don't have the activity of that enzyme? First of all, you will see right away that you cannot get that glycogen back to mobilization, that you have that extra storage you can use when you don't eat. Of course, this is not the only way to get glycogen mobilized, but this is a very important factor in getting the patient's hypoglycemia, so low blood sugar levels. And you recognize probably many of your children had low blood sugars with CDG. It's a common symptom and not only related to this deficiency, but also many other defects. So what happens next? You have a problem with this part of the pathway as well, because there is the block. And you want to have your glycogen mobilized, and you want to have your galactose to all get activated and get into glycosylation. But what you measure in the fibroblasts, so the skin biopsy cells of these patients, that this goes up because it cannot go further on, and this goes up as well, but this is more distant from the stop. So both metabolites will increase, but the ratio of the two metabolites is abnormal. And actually, this is higher than this one. And the strange thing we measure in these patients, that only this change in the balance, that this is more elevated than that, would totally decrease glycosylation. So that little balance change that is not flowing so nicely to the glycosylation pathway, it's enough to cause the disease. So you saw already this slide. Just remember, these patients have liver involvement, low blood sugar, then the cleft, then they have myopathy, so they are weak, and they also have growth retardation and hormone problems. And the worse if they have the cardiomyopathy. So, is the answer in milk? First of all, I interviewed all the parents how much milk their children is ingesting. So it seems like there is a tremendous variation. And then I just calculated how much milk someone drinks just age appropriately. And then if you calculate for a newborn, they eat between 3 to 4 grams per kilo per day. And then if you calculate for somebody who's before puberty, it's just 0.3 gram per kilo per day. So there is a normal variation. The question is, what happens if you elevate that intake, but only stay in the normal range? So don't go higher than the normal intake, just try to get to the normal intake. Would it matter for the patients? Would they get better? So another thing we did, we gave complex carbohydrates to our patient because we wanted to prevent low blood sugar levels. And that was something additional, what we did by all cases, and that worked fine. But that's the routine treatment. And the other research question was, if we give either milk or lactose, which is the complex form of milk sugar, or galactose, which is actually the yellow dot I want to build into my antenna, but just give as much as you would normally give with milk, would it change anything in the patients? So this is one patient's study, and you see that in 2 months, that crazy leather pattern started to improve and very similar to control. This is a normal, healthy patient. So that's pretty promising. We just gave galactose, just milk sugar, to a very severely ill patient, and as you see, the biochemical pattern already improved. So that's very promising. So far, we tried galactose in 5 patients. So what you saw, the liver function improved significantly. You saw normalization of the hormone levels because they are also glycosylated. And their coagulation factors also got better. So this sounds terrific. It sounds really promising. But is this already safe enough to start all the patients on galactose treatment? So Dirk measured actually the effects of the galactose on the antennas, on the sugar chains. Remember, we can measure it and we can see how it looks in a normal individual. So in a normal individual, you see almost all antennas are normal, and sometimes they are in the make. And in our case, when we started to treat, look at that crazy antenna pattern above. They are all the sick patients' antennas. And after milk, or not milk, milk sugar treatment, we saw a much better picture. So are we there yet? We proved that we are doing something. We measured that the transferrin is getting better. We measured that the antennas are getting built better. We also measured that the patients have better hormones and better coagulation. So here comes the difficulty. This is not a study. We had some individuals who gave us informed consent, and they said, we want to try galactose. It's just a dietary sugar. I want to take it and want to see if I get better. But it was not like a full prospective study. So look at this patient. She was before puberty. So how can you tell whether these hormones, which are going up nicely and seem to get normal on the therapy, is this just by chance, are just lucky and the patient went to puberty, or we are geniuses and we just found therapy in a new disorder? So the patient is doing fine, and so far, the most important I can share with you that nobody had any side effects. When we found this new possibility for treatment, Professor Fries came up with the idea that we should share this idea with the CDG community. So we didn't really keep it as a secret, but we sort of offered the protocol to parents and to colleagues to let them overweigh if they want to go ahead and treat their patient and sort of get back to us and tell us what their experience was. And so Professor Marquardt also did therapeutic studies and tried the patients on lactose. That's the complex form of milk sugar, and also on galactose. And he has only also experience with the effects. And if I might say, and correct me if I'm wrong, the patients on lactose, so the complex sugar, they did well for some time, but then it leveled off. It was not so spectacular as we see in our first patient who has the longest follow-up. Charles Stanley here in the US, he started his patients also on lactose, that's the complex sugar, and what he sees that the patient is getting better every month and has no symptoms whatsoever, but the hypoglycemia didn't go away, so he has to give a special medication for the hypoglycemia. So this is all promising, but now we have to stop and think that we really need a study. So we really have to get together, all of us, and that's what we actually want to do, to start a multi-center study and a prospective study that we will collect the data of the patients, do the same protocol, and feed the same sugar to these patients, and then after a year, see whether it was safe and if it's really working as well as we thought. So I have to wake up, Mark. I'm so exciting. Let me show, it's the jet lag, but while I'm speaking, I'm alive. Yeah, let me tell you this. I've been on a conference where somebody was invited from the US, and he fell asleep during his own speech. He was talking, and then the audience had no idea what's going on. So my message is to you. We are very excited that it seems like we have a new disease we can help with a simple dietary intervention. This galactose powder is on the internet. You can just buy it as a supplement, as a dietary supplement. So that's not the issue. We want to be sure that this works before we sort of start to treat anybody who's coming with, yeah, I want to try it. So what we want to do, we would like to share this knowledge, look for the patients also through the website, and we can reach out to these patients and through these patients to their doctors, and probably we'll have over a year a great story to tell you how this is working and how can we figure out new ideas about this to help your child in the future. Thank you for your attention.